bigger follicle even before we start ovulation induction itself. So it's no longer one, it's not about what you give, it's about how the way you give. So let me introduce one of my patients. She is a young couple, married for 4 years, primary infertility, irregular cycles with high BMI, otherwise everything is normal. So what is that which immediately pops into your mind hearing this? So what is that which immediately pops? We think it is a PCO. Yes, it is a PCO patient, but it could be a variant of group 1 hypo case also. Because it can be, because patients with vigorous exercise or in extreme stress levels also can present with irregular cycles and a high BMI, and it can be a case of group 3, WHO group 3, where a low ovarian reserve patient can also present with irregular cycles, hypomenorrhea and obesity, or it could be a simple case of hormonal imbalance where by correcting hyperprolactinemia or correcting thyroid disorders or correcting adrenal gland dysfunctions can immediately restore her ovulation, and automatically patient can ovulate and become pregnant. So we have done our labs, everything is normal except that her LH is a high LH PCO and her testosterone levels and DHA is in a higher limit of normal, which is very common in a PCO patient. So before starting ovulation induction, is it mandatory to correct high LH before starting ovulation induction? No, it is not routine. So there is high quality evidence which says that routine suppression of LH prior to ovulation induction is not recommended, and it is good to hear that letrozole works regardless of LH. So coming to lifestyle factors, consumption of alcohol should be decreased. Tobacco in any form, not only in the form of smoking, but also gutka and pan chewing. Usually we overlook this factor, gutka and pan chewing. Tobacco in any form should be complete no-no. BMI should be in the ideal range because high stress and poor sleeping habits also causes increased cortisol. So pregnenolone is the hormone which is responsible for making cortisol and sex hormones. So extreme stress robs the sex hormones to meet high cortisol production. So we have to make efforts to decrease the stress levels of both the patient and doctor also. So coming to ovulation induction proper, is it ovulation induction or ovarian stimulation? What is the difference between ovulation induction and ovarian stimulation, and what to choose in which patient? So ovulation induction is we aim for monofollicular development. Whom we do it, the patient is not ovulating before, which we usually encounter in a PCO patient. Ovarian stimulation, here we aim for 2 or 3 dominant follicles. So whom we do it in case of unexplained infertility patient is already ovulating with 1 follicle, and again aiming for 1 follicle, we are not doing anything, better for the patient. So in case of elderly patient, unexplained infertility patient, and in case of mild endometriosis patient, aim for multifollicular development, but not too many. Maximum is 2 to 3. So what is there in our armamentarium? Oral ovulations like clomiphene, heteros and tamoxifen, injectables, gonadotropins, and GnRH analogs and adjuvants. Who is the best? Oral ovulations or injectables or combined protocols? What is best? So coming to, I'm not going in detail because this session is covered before in the early hours also. I just want to give a brief outline of it. So clomiphene citrate, yes, it is an age-old drug. I think most of us stopped using clomiphene, but I still see many prescriptions writing clomiphene citrate. So I just want to give a brief idea about it. Clomiphene, it's a selective receptor, SERM. We have to, the initial starting dose is 50 milligrams from day 2 for 5 days. If the patient is ovulating with 50 milligrams and not conceiving, try not to increase the dosage of the drug in the next cycle. Don't think that we have given 50, patient didn't conceive, so next increase the dosage of the drug. No, if the patient is ovulating with 50 milligrams, don't increase the dosage of the drug. If the patient is not ovulating with 50, next increase the dosage of the drug to 100, 150 or maximum 250 in the same cycle or in the next cycle. But doses above 150 milligrams is not of that useful. Ovulation rates are higher, but the pregnancy rates are less because of the anti-estrogenic effect of the clomiphene citrate. Letrozole, yes, it has moved from shadows into the center stage. Letrozole is an aromatase inhibitor. It is given in 2.5 milligrams OD or BD dosages, and there is an age-old battle. Which is better, letrozole or clomiphene citrate? and there is a good quality evidence. There are many studies, meta-analysis, which says that in a PCO patient, letrozole is the preferred drug because of the higher live birth rate, pregnancy rates, and the ovulation rate, and few risk of multiple follicles, fewer risk of OHSS. So, but in an unexplained infertility patient, letrozole is an effective alternative. But in a PCO patient, letrozole is the drug of choice. Tamoxifen, yes, it is the drug of choice, especially in thin endometrium patient. The dosage is 20 milligrams OD or BD dose, but it is not used commonly because of its side effect, because the safety profile is lacking. So, my case continues. Here I have given letrozole 2.5 mg BD for 5 days and scanned her on the 9th day. But there is no dominant follicle. What to do now? Should we cancel the cycle or change it to clomiphene citrate next month, or increase the dose to 7.5 mg in the same month, or add gonadotropin? Which gonadotropin if I want to add? If it is it FSH or LH? Or what is the role of adjuvants? Or should I directly jump into laparoscopic LEOS? So what else can be done in a resistant PCO case? So there is good quality evidence that immediately in the same cycle start with higher dose. If you have given 2.5 mg, increase it to 5 mg, or if you have given 2.5 mg BD, that is 5 milligrams, increase the dose to 7.5 milligrams. For the next 5 days, scan after 1 week of the last pill, increase the dose till you see the dominant follicle. So there is a good quality evidence which says that letrozole step protocol, by using this protocol, the ovulation rates are higher and the time to pregnancy is less. Then what is this letrozole extended protocol? Where we use it? If we already know that the patient is a resistant PCO, we have already checked her follicular scans, which says that by using letrozole or clomiphene, whatever, it's the same. By using letrozole 5 mg, we didn't get any dominant follicle in the previous cycle. Then this is the patients. Rather than increasing the dose of to 7.5 mg for 5 days, it is better to increase the duration of the drug for 5 mg for 10 days. So there are many studies which says that rather than increasing the dose of the drug, increasing the duration of the drug gives good quality oocytes, increases the ovulation rates and pregnancy rate. So letrozole extended protocol is better than the step protocol if we already know that the patient is a resistant PCO patient. But in the same cycle, to avoid cancellation of the cycle, you can use letrozole step protocol. So what is this combined protocol? So does it really work, combining letrozole and CC in the same cycle? Yes, there is enough evidence that giving letrozole and CC in the same cycle, letrozole in the morning, clomiphene citrate in the evening for 5 days, increases the ovulation rate compared to letrozole alone. So where we use these combined protocols? In poor patients who are not affordable for gonadotropins, or in patients who are contraindicated to gonadotropins, we can use this combined protocol. Even we can view, if the patient is not responding for letrozole by increasing the drugs, in our practice we have observed that by giving a sequential letrozole and clomiphene citrate also, there is a good quality evidence that the dominant follicle is selected, but don't routinely use it as conventional protocols. So safety. This is a very controversial topic. What is the maximum number of ovulation induction cycles? So yes, there is a evidence says that maximum is 6 cycles. But if you are not getting success rates are maximum in the first 3 cycles, and then the success rates plateaus. So, but when you give ovulation, there is evidence that when you give ovulation induction for more than 12 cycles, there is slight increased risk of borderline ovarian cancers. So be very careful when you start on, go on giving ovulation induction cycles. So, but there is no significant increased risk of congenital anomalies. So it is like giving hint, try to stop. Audience are exhausted. Okay. So coming to adjuvants. So I'll rush fast. So adjuvants, insulin sensitizers, metformins and inositols, they increases insulin sensitivity. They are used synergistic to letrozole and clomiphene citrate. They increases the ovulation rates and increases the pregnancy rates, and they are good in obese and resistant PCO patients. They reduces the risk of OHSs also, and the quality evidence is also good. Dexamethasone, interesting. So which patients we give it? In PCO patients who are hyperandrogenic also. How we give it? Prednisone, how we give it? Dexamethasone 0.5 mg OD one time in the night time HS. Or if the patient is not responding for 0.5 milligrams, you can increase the tablet dose to 1 mg. That is 2 tablets in the night time. How to start it? We have to start along with the oral opioids. Till when to continue it? We have to continue it till trigger. So, whom it is useful? Hyperandrogen PCO patient, and the quality evidence is low. L-carnitine and vitamin D, yes, we can use it, but the quality of evidence is low. Second line, gonadotropins versus laparoscopic ovarian drilling. Gonadotropins, yes, the efficacy is good. Ovulation rates are more, conception rates are more, but it is like a double-edged sword. Why am I calling it as a double-edged sword? It increases the pregnancy rates by increasing the number of follicles. It increases the oocyte quality. The endometrium, while we are using gonadotropin cycles, is also of good quality. But it carries with it the risk of multiple pregnancies, OHSs, and cycle cancellation rates. So, which gonadotropin, FSH and LH? Yes, both have good quality. Both are equal regimens. Gonadotropins can be given alone, or it can be combined with oral opioids. So, before I talk much about gonadotropins, I would want you to understand the concept of FSH threshold and FSH window. FSH threshold is that the growth of fertile follicles starts when FSH levels rises above the threshold level. Threshold differs for different follicles and depends on the sensitivity of the follicles to FSH, which in turn is dependent on the number of FSH receptors present on the follicle. Whereas FSH window is the duration of time FSH is above the threshold. It determines the number of follicles selected from the recruited cohort. Longer as the window remains open, greater is the number of follicles recruited. So how we use it in our regular practice is that, suppose you want in a PCO patient, you want monofollicular development. So by giving gonadotropins in the later half of the follicle phase, like you oral ovulations in the first half, to increase, we want only monofollicular development in a PCO patient. So give gonadotropins in the later half of the cycle. But in unexplained infertility patients where we want more follicles, give gonadotropin in the first half where the window is still open, so that more and more amount of follicles are recruited. So gonadotropin alone regimens like step down protocol in which we use higher dose of gonadotropin and decrease, and when the till the dominant follicle is selected, then decrease the dose of the gonadotropin use. I'm not going into details because we are not using in our regular practice. Step-up protocol is that we start with a minimal amount of the drug. If the follicle is not selected for 1 week, scan after that. If there is no dominant follicle selected, we increase the duration of the drug for 1 more week till the dominant follicle is selected. So chronic low-dose step-up protocol is the protocol of choice in PCO patient and which gives good results, but the compliance of patient is bad. Adding oral opioids, it lowers the required dose of gonadotropins, lowers the cost, decreases the multiple pregnancy risk, reduces the OHS's risk, and yes, without affecting the efficacy of gonadotropins. So laparoscopic ovarian drilling, whom to do? It is very good in young, lean PCO patient with high LH and high androgens. When I like the point where Raumberg sir told in morning, don't drill too much because sperm doesn't like burnt eggs. So this is very important slide. When not to drill the ovary, this is very important. We should not drill ovary when the volume is less than 10 mm3, when the FSH is more than 10, or in case of previous drilled ovary, don't ever drill it again. So now in my case, she has developed a dominant follicle of 16 mm, but her ET is only 4 mm. So what to do next? So check on the drug. If you have used clomiphene citrate, change it to letrozole. If you use letrozole, change it to either tamoxifen or gonadotropins and add exogenous estrogen. Exogenous estrogen, when to add it, what is the dose? Exogenous estrogen 2 milligrams OD or BD or TID depending upon the patient, depending upon the requirement. So when to start it? Start only when you see dominant follicle more than 14 mm or 16 mm. Why? What it happens when we start before? Because estrogen suppresses the FSH. So the dominant follicles get strained. So it is better to start whenever after seeing the recruitment of dominant follicle. So there is always a doubt when to stop it, whether we have to stop till trigger or whether we have to stop till our pregnancy test. So there is evidence which says that both doesn't make any difference. So you can continue it till trigger or till pregnancy test. Most of us like to continue till pregnancy test. So among adjuvants, exogenous estrogen remains the only evidence-based guideline-supported therapy, and vasodilators like sildenafil, pentoxifillin and vitamin E may help in selected refractory cases, but current evidence is limited and low quality. So again, dominant follicle now got selected 20 mm, ET is 8 mm. I have given trigger HCG 5K, but I forgot that the patient is obese. I have given HCG 5K. I have checked after 36 hours, follicle has not ruptured. So what to do now? Increase the dose of the drug to 10K or give agonist. Someone said agonist is better, some give agonist. Wait for some more time, or what do you do in the next cycle? How do you plan it? So HCG 5,000, 10,000 doesn't make any sense. Dose is usually individualized to reduce the risk of ovigescence. Agonist trigger is not usually given in ovulation induction drugs because it is short acting. It causes luteolysis. Because of it, it causes luteal phase defects and decreases the pregnancy rate. So dual trigger is the trigger of choice, but not now. We have to plan it in the next cycle. So next cycle, make sure the diagnosis of LUF is correct. Scan on the day 2, rule out the cyst. So what to do? We get a doubt. We have seen cyst on day 2. So whether to give ovulation induction or whether to proceed for ovulation induction or not. So whenever you see cyst on day 2, check hormones, estrogen and progesterone. If the hormones are more, yes, you give OC pills to suppress it. More means what? If the hormones is more than 100 or 150, use oral contraceptive pills to suppress the cyst. Or if the hormones is less than 50 or like that, you can safely proceed with ovulation induction, but try not to give gonadotropins because it might sometimes, increases the size of the cyst. So, appropriate follicular monitoring and timing of the trigger is very important. So, trigger only when you see more than 75% of the surface perfusion is there, only when PSV is more than 10 and RA is less than 0.5. So, now I have seen very good dominant follicle, 999 endometrium, but the PSV is only 8. What to do now? Dominant follicle is 20 and I like the beautiful endometrium. Then my hands itch to give the trigger. So, but the PSVs are less. What to do now? But don't ever give trigger in such cases because it might most of the times leads to LUF. So, wait for 1 day or more. Check PSVs and give trigger only when PSV is more than 10 because rising PSV and decreasing RI indicates follicle near to rupture. So, in this case, avoid NSAIDs at the time of the trigger and give GCSF 300 micrograms 48 hours before planned trigger. That is, whenever you see dominant follicle 16 mm, reminder, if the patient is a known case of LUF, give GCSF. How does it act? It causes increased leukocyte infiltration, which aids when we give trigger, it aids for rupture of the follicle. So, dual trigger is the most evidence-based intervention for recurrent LUFs. So, luteal phase support, yes, it is required more so in gonadotropin cycles because supraphysiological hormone levels in this cycle suppresses the endogenous hormones and FSH and LH and it causes luteolysis. So, either vaginal micronized progesterone or oral dydrogesterone is good, and yes, thank you.